Good morning, everybody. Welcome to Intellectual Medicine. This is Dr. Petteruti here with you, the voice of Southern New England, WPRO. And today we have with us Carolyn and Paul. They're going to share with us their journey. Paul was diagnosed with a glioblastoma, which is a brain tumor, generally considered to be fatal. And he's here of clear mind to talk about his experience, their family's experience. You know, folks, we all have that fatal condition called life. And we all get up every morning ignoring the inevitable. You know, we ignore the shadow that looms over us so we can get through the day, so we can enjoy the moment. Enjoying the moment by virtue of making peace with our mortality is innate to all of our walks. And yet, when it becomes much more acute, when you have a clear and present foe, things can change a bit. So we're going to hear from them about the psychological aspect, the personal aspect, and yes, the medical aspect as well. Hopefully, none of us have to face this. Some of you already have. You know, the knock on the door, the moment where you are told, you know, you have a diagnosis, and now it comes fast, right? You have to make decisions, and the machine, I'll call it the machine, the healthcare machine lovingly embraces you as they attempt to try to direct care. This is really, really hard work on the part of doctors and nurses, and it's difficult on the part of patients. The information is baffling and can be overwhelming. And I study this, of course, every day. This is what we do. And anybody who claims to have cornered all the knowledge is not telling the truth, because it's just too overwhelming. So Paul and Carolyn, I promise they'll be on the air. I'm going to stop yakking in a moment. You know, but first, as always, people, we have to scan the world. We have to look at the milieu in which we live. So, you know, Paul and Carolyn are going to be talking about cancer, their experience with it personally, but it's against a backdrop that affects everybody. Now, that backdrop connects different aspects. Okay, so here's one thing. When I was growing up in medical school, brain tumors were rare. I mean, we saw a glioblastoma. It was an event. Mm-hmm. Good Lord, they seem everywhere. And so I did some research, and in fact, it's not just my perception. The rate of glioblastomas is more than doubled over the past 20 years. And nobody knows what causes them. They're not genetic. We see other forms of cancer that are also skyrocketing. Colon cancer in people younger than 50. It's blowing up. Pancreatic cancer. What the hell's going on? Well, part of this thread can be connected, I believe, and there was an article where they reflected on some of the etiologies, and one of them has to do with exposure to ionizing radiation. CAT scans. You can't stub your toe and go to an emergency room and not get CAT scanned 82 times. I'm telling you, it's an SOP, standard operating procedure. You bonk your head, you can get an fender bender, get a bloody nose. If the airbag deploys, you're getting a CAT scan. Now look, I get it, right? We want an abundance of precaution. I can't stand that phrase. An abundance of precaution means we're not going to think too hard. We're just going to fire. So CAT scanning has become so pervasive, and it is nearly impossible to track causality because of delayed consequence. So my caution to my regular listeners is push back. They want to do a CAT scan. They need your permission. You can say no. In fact, if you have the mental clarity to say no, you probably don't need one. It's like, so you wanna be mindful of that. The other thing is this electromagnetic radiation. What are the cell phones, right? What are they doing to our brains? We don't know. Now look, I'm not about to abandon my cell phone. Good Lord, what would I do if I can't check the sports scores every 10 minutes? You just never know what the Patriots might be doing at 2 o'clock on Wednesday afternoon, right? Inquiring minds need to know. Oh, so I like the hands-free stuff to protect your brain and keep it a little far away. So the other thing that connects to this is toxicities. Now we have an ongoing debate in Rhode Island. You guys are out of state, but really Rhode Island, New England, let's get over ourselves. We're not really a bunch of little states. We're like one state. Rhode Island is like a county in the state of southern New England. And if we start thinking like that, we'll be better off. if a business moves from Pawtucket to Attleboro, does anybody really care? As long as my job is good, my median income is strong, so you get an opportunity to have more freedom. So now we have to talk about freedom, because without that, well, why even get out of bed, right? That's what we died for as a nation. Freedom of speech, freedom of thought, freedom to innovate, free enterprise. And with freedom comes inevitable inequalities. Now that may sound like a horrible thing. Good Lord, I'm in favor of inequality? Well, I'm in favor of freedom of outcome, which means, well, inequality, because it's not going to be the same when freedom reigns. So here we talk a lot of late about income disparities, and that's something called the income gap. And we want to draw a connection between the income gap, the significance of wage, freedom, and the ability to treat your cancer when it happens. And these things kind of connect. So the income gap, meaning the gap between median income and upper income. Let's look at that. The 90-50 gap, the people at the 50th percentile in America versus the 90th percentile. That gap of median income in the U.S., $45,000 a year. The top 90 percentile, $108,000. That gap represents a 2.4 differential in 2017. In 1997, it was a 2.2 differential. So yes, that gap has widened. What to do about it? Income redistribution and tax policy will fail. It's failed every place it's been applied. The reason the gap is occurring, it's not because of tax policy, it's because of productivity differentiation. Simply put, we're a more technological society, and if you have technological skills, you will leverage that into greater productivity. You're going to make more money. Suppose you're in that bottom portion. How do you become, well, how does your wage go up? So let's talk about that difference for a moment. The wage is what you put in your pocket. That dictates your material quality of life. So the differential is one variable. Put it this way, would you rather live in, Yemen and have a differential of nothing? The median 50% is making $1,000 a year, and the upper 90 percentile is making $1,200 a year. Well, there's no differential there, but everybody's feeling equally miserable. That is a form of equality. In the U.S., we have a median income that's 6% higher than Germany and 17% higher than the United Kingdom, even though the differentials are smaller. I'm not advocating reckless growth of the upper at the risk of the lower. That is where conscientious capitalism and strong unions, dare I say it, are part of the equation, because you've got to be able to extract compensation. But without productivity, you're hopeless. So the way to get productivity is through skills. In Rhode Island today, in southern New England today, you're struggling to find men and women who can operate a backhoe, who can run electrical wires, who can run plumbing. You want to reconstruct the roads, good luck finding people to do it. Meanwhile, we're in the cult of college. I'll call it the cult of college. Everybody's got to have a degree. In fact, we're going to pay for it. We're not going to pay for some poor son of a gun to become an apprentice electrician. We'll pay for JoJo to go to junior college and study sociology for a semester. Anyhow, so it connects back into this because, you two have experienced the consequence of the immediate pressure of having to make decisions and having to use discretionary income and divert it into your health care.
Mm-hmm. Correct.
And that's one of the ways where freedom can be absorbed. If the only treatment that will be paid for by insurance is mainstream, let's call it that, and that may be quite appropriate, right? That's what it's there for. But what gets covered and what doesn't? Now, in intellectual medicine, we offer intravenous vitamin C and mistletoe therapies. These are not approved by the FDA. I have to put my disclaimers in here. Now, this show is potentially hazardous to your health, as the things we discuss can be misleading and confusing. Okay, people? So put on your thinking hats, because we have to discriminate. And when we come back, we're going to pivot from the financial well-being to the up-close and personal effect and decisions that people have to make in their families, and the decisions Paul and Carolyn had to make when the knock on the door came and the diagnosis was rendered of the brain tumor, the glioblastoma. So we'll be right back. We'll let Paul and Carolyn have center stage. In the meantime, we'll take a short break. This is Dr. Petteruti. You're listening to Intellectual Medicine. Sorry about that. I got kind of carried away. But these things very much connect. You know, median income, freedom. Freedom is nothing unless you have the ability to make choices.
Right.
And there are a couple of ways freedom gets robbed. One of them is, well, they'll take all your money. So you can, because you understand there's an element out there that feels they know better than you do what you need. And if you think you have the right idea, well, it's because you're really not really bright enough to figure it out.
Yeah.
And we're going to make the decision for you.
And we don't even think about it yet from the financial point, because my boss is still paying for me, which is he's still paying my salary 7 months later.
Well, because it's not crazy, because you're a great person and he values you as an employee.
But I mean, we're blessed with that.
But it becomes, well, that's one of the things we're going to talk about. In fact, we have a Facebook Live audience right now. Guys, Shannon's not with me. She is at Owen's lacrosse match. Very important. Now, Shannon is my partner in all of this endeavor. She's a nurse practitioner, extraordinarily highly skilled and well-trained in every aspect of intellectual medicine, including the complementary cancer support that we render. And I share that with you guys and with my listening audience in case anything were to ever happen to me, that our journey goes on. In fact, this form of care is becoming more and more widespread. I'll be in Orlando next week, and the topic I'm going to be delivering is intravenous vitamin C and mistletoe therapy, its role in secondary prevention of cancer, and the role of liquid biopsies. Absolutely riveting, innovative stuff. 1 minute. And those are the things that we deliver, and although I've been invited to speak to an international audience at a CME-sponsored conference, Continuing Medical Education Conference, that exact topic is something I have to defend myself against on the part of some doctors who think it's snake oil. And these are good doctors, too. You know, my critics are good doctors. They're not bad or evil people. They just have a visceral negative reaction. I liken it to the Reformation, Martin Luther. I think it's because I don't know if we have time to get into this, but we're about to go back on air. Maybe we'll do it in another segue. Okay, 10 seconds. We'll talk about Martin Luther and the medical reformation that's happening right now. I'll do that during the next break. That's our Facebook audience. They get cool stuff. Income gap. Hey gang, we're back. It's Dr. Petteruti. All right, so here's the thing. Let's set this record straight. It is not Mother's Day tomorrow. I'm changing it. It's Mother's Day weekend, and I'm declaring it a 3-day weekend. Okay, everybody, take a deep breath. You like that?
I like that.
It's a 3-day weekend. If you don't get to the brunch tomorrow because you forgot and it's sold out, and you can't get flowers to your mother because, well, you were a little busy and you let it slip your mind, don't worry about it. Monday is Mother's Day Redux. All right? Is that good? You like that?
Sounds good to me.
I did all that because I just screwed up and I had absolutely no plan at all. And fortunately, my mom does not listen to my radio show. She has no idea she's getting nothing for Mother's Day. But by golly, I'll be there Monday, Mom, and it'll be awesome.
That's good.
All right. Well, listen, guys, lean up to the mic because I want to turn it over to you both. So you're living a good life, married, 3 kids, things going pretty well.
Yeah.
Yeah,
And then, you have an event that you share with me. Well, talk us through that, the early stages, what was going on and how it affected you and the onset. I'm interested in the symptom to the point of diagnosis. That had to be just powerful.
Sure. So there was definitely the symptoms that we were seeing was, depression, lots of headaches. And then on a boat one day, somebody had noticed that there was some drooping and slurring stroke-like symptoms. And they said, get yourself into the hospital right away. You're having a stroke. And it worked out to be with a scan, with a CAT scan, as you love, right? Yeah. About half an hour later or so, they found a 4-centimeter tumor, about 1.57 inches.
So there represents a wonderful indication for a CAT scan.
Yeah, that's right. That was a good one. There,
if you think you're having a stroke. So they found the tumor.
That was on September 16th, and 4 days later, We had surgery to have the greatest portion of it removed. It was a very successful surgery.
That's fantastic. So the surgery was a critical element of it. The emergency room acted quickly. CAT scan was available. These are aspects of our healthcare system that actually are pretty good. You know, when you're in an emergency environment like that, they snap to.
Right.
So there it was. The tumor's removed. Holy cow! You hardly had a chance to exhale in this hit.
Oh, and it was fast. Yeah.
What happened next?
Well, the next thing was, what's the level of care that you're going to have? They had to do a biopsy on the tumor to find out if it's unmethylated or methylated.
So what kind of cancer specific?
Well, this is a glioblastoma
Right.
multiform stage 4. So there's 125 different brain cancers. This is the worst brain cancer you can have.
You don't screw around.
No. And then what makes it one step even worse can be if it's unmethylated versus methylated.
Right.
And we're waiting for those results because that would dictate whether you get the standard of care or not, you know.
Right.
And if it's unmethylated, you wouldn't get the standard of care, which is Temodor and radiation. You would get some other chemo. Well, in our case, they said, our cancer institution said, if you are proved to be unmethylated, we're going to suggest you go on a trial. If you go on a trial, you'll be automatically selected for a different medicine, a different chemo other than Temodor.
So it would offer some hope.
It offered some hope. We're going to
Sure.
get something different than the Temodor, which was proven not to help unmethylated. So we got into this trial, and go figure, it was a 4-arm trial, meaning 4 different medicines.
Right.
And we were selected for the Temodor nonetheless.
So the Temodor is the drug that was known to be ineffective for
Correct.
your type of cancer.
Correct. So
Carolyn,
about...
you wanted to add something.
Yeah,
Carolyn.
little to nothing. In the methylation, what that means is just the genetic makeup of a tumor.
Right.
Everybody, if it was a methylated tumor, the prognosis would have just about doubled.
Better prognosis.
Better
longevity.
longevity.
Better
for the
response
tumor.
to the chemo.
Yes, I want
So,
to add that.
For our listeners, these are the nuances that you really want to dial into. 125 different types of brain cancer. Now that's just one organ. Now you get an idea about the daunting task we have when it comes to research. Then you get into the details of cell type that are being studied and broken down. And in some cases, they can look you in the eye and say to you, this chemotherapy has been proven to be effective. Boy, when you hear those words, that's comforting, and you sign up. What happens if they say, well, it might help a little? That's unsettling.
That's exactly what we got.
That's what they said.
So you're in the study, and they have one arm of the study with a drug that they don't have much faith in.
That's right. And we countered that by saying, well, why would I go with the Temodor if you guys clearly said before the trial even began, why would we do that? So, well, it's a computer-generated selection. We have no control of that. So though you're unmethylated and Temodor doesn't prove to work well, we can't change it.
Now, at that point, what did they tell you about your prognosis? You have this brain tumor. How long do you have to live?
They said the mean, meaning 50% of all people are lucky enough to make it 14 months.
Okay.
So they're hoping that now with it being unmethylated, we would still see that 14 months. Well, it's been 7 months now, so halfway there.
So
Yeah.
it's a good start.
We want to go past that.
Absolutely.
That's where IM comes in.
So that's where intellectual medicine comes in. It's our
That's right.
and
Get a little plug in there.
Well, the idea here, part of our raison d'existence, a reason to be there, is to support and complement that which is available and successful, or in some cases when there's little good alternative.
Mm-hmm.
So you got that information. Are you in that study currently?
I'm still in the study. I'm
Yeah.
in the middle of my 5th round of chemo that just started a couple days ago, and they want me to do 2 more rounds after that.
Right.
We're on the fence right now if we do any more chemo. We're doing a lot of supplements right now.
Right.
They don't want us doing supplements.
So you're doing the supplements on the QT.
On the QT. We told them at one time what we were doing for supplements, and they opposed them. If you're on a trial, no supplements, no change in your diet. Well, we've changed our diet radically too.
Why would they want you to not do anything else when you're in the trial? Did they give a reason for that?
They didn't. They just...
I believe they're looking for what the average person would be doing.
Okay.
I am on a Facebook site somewhere, and a lot of people haven't changed their diet
Right.
And we believe we are on the Budwig diet. My aunt, who has leukemia, never did any doctor care, just checks her blood, and she has her leukemia under control because of a diet. So we figured we're going to change his diet. It's
Sure.
a vegan-based diet. We're going to put the nutrition into his body that it's lacking.
So one of the things, certainly, one of the answers to the question is the study becomes more important than the patient.
Exactly.
And the study protocol, in order to be good science, needs to control variables. This is not really patient-centered anymore, and it becomes study-centered. Now, we know from research, the majority of patients that have cancer do some form of complementary care. And in many cases, it can be difficult because you don't know who to talk to about it.
Mm-hmm.
It's almost like, I don't know, you've gone to the dark side
Mm-hmm.
and you're doing Budwig. And if you mention it to some oncologists, they get angry or they rebuff it. And really, one of the things that I have found in the patients we serve is a desire to engage and to have that kind of conversation. And for those of you listening, I have found that there are many wonderful oncologists that are open-minded. And what I love is when an oncologist will say, well, I don't know much about vitamin C or mistletoe, but as long as it's safe, it seems reasonable, I don't have any objection. And the studies have continually supported the safety. So with regard to some of the complementary care, here is our criteria before we bring it into our shop. Number one, is it safe? Has it been proven in human experience to not cause harm? Okay, mistletoe, check. Vitamin C, check. The studies are abundant and they're out there. Properly administered, safety is enormous. The next one, does it have any evidence of effect or benefit? That evidence can be in vitro, that is in a petri dish against cancer cells, or in animals, ideally in humans. With both mistletoe and with vitamin C, the answer is yes. In the case of mistletoe therapy, the evidence for glioblastoma is more limited. There was a study in 2000 that showed a delaying of growth of glioblastomas in xenografts. That's when they take human cancer cells and they implant it into an animal and then they subject it to treatment. That was very encouraging. In fact, it was so encouraging that they advocated for further studies. Those studies never happened. There's a lack of funding. Mistletoe therapy is a natural substance. It's a non-patentable entity. It's hard to generate the type of multi-million-dollar study when there's no net gain at the back end of it. If they can make a drug out of mistletoe, we'll see the studies occur. There's another one. This is from Cancer Cell 2017 out of the University of Iowa. And I'm going to quote it. Ascorbic is safe and efficacious in combination with radiation and chemo. This was in regard to glioblastomas. There was a study in 2018. It was a case study. A woman with a glioblastoma who was living past 4 years with a diagnosis and a prognosis that was supposed to be terminal in 12 months. Now that gets dismissed by some as being anecdotal. We consider those case studies that are supportive. And you guys know, right? Vitamin C, not going to cure cancer. It's not known to do that. Mistletoe is not known to cure cancer. We also know that we're operating in the realm of the unknown. So I had a patient. I'm going to tell you about this patient when we come back from our break, and it ties into what you guys are doing in the decision-making process. And then we'll talk more about your experience and how you came to make the decisions that you did. But before that, we have to take a short break. Up next from the Revolution Softwash News Center, it's Doug Lizette with today's headlines. Good morning, Doug. I don't know, it seems kind of weird talking about cancer and then Softwash News.
Yeah.
So Softwash is they wash your house.
Oh, okay.
I didn't know what it was.
Wow.
So I'm saying this time every week, Revolution Softwash News. I don't know, it's a car wash.
Wow.
And so I'm looking at the roof of my house, and there's all that mold on it.
So quick power wash then.
Yeah, not even. No, you don't power wash it. See, now I know.
Oh,
Because
wow.
I had the guys come to my house, right?
Yeah.
Come with a clipboard, and they're doing all that so they can charge you triple, whatever. So anyhow, it's a chemical they put on it. It kills all the mold and the mildew. And then, because if you power wash it, it'll damage
Yeah.
the material.
Yeah.
So then you're breathing in those chemicals as it's spraying down on you.
Good buzz, right?
Mold, maybe mold will be the
Mold
anecdote.
might be the-
You never thought mistletoe.
You know?
When I first heard about mistletoe therapy, I thought to myself, you got to be kidding me.
Mistletoe.
Are you
What
kidding
did I
me?
tell you? Are the people going to kiss me to death? That's what I thought about.
We're going to overwhelm you with kissing viruses that will
man.
suppress the tumor. Oh, boy. So we're talking about something. Oh, I know, the Reformation. So I want to give my analogy to my Facebook audience. We're in an era right now of what I like to call the medical Reformation. So like the religious Reformation of Catholicism, it happens when the grassroots people gain direct knowledge. So once upon a time, nobody could read. There was no printed word because you need a scrivener to copy stuff. So getting a Bible, you had to be rich and you had to be capable to read it. So nobody could read. A bunch of illiterate people with limited editions. So you had to go to church, and the priest would tell you what the Bible said. Now, I'm a of Catholic origin, and I love the church, but nevertheless, history is what it is, right? They would tell you what it said. You can't read the book because you're too stupid. It'll confuse you. That was the essence. Now, picture medicine in 1990. We had the book. You didn't. You couldn't go to the internet. It didn't exist. And you had to rely upon me because I'm the high priest of medicine. I'm going to tell you what the book says, and you're too dumb to figure it out, so don't even try because you'll be misled. You'll get confused. It'll hurt your brain. Now comes the internet, and everybody I know, you get a diagnosis of any substance, you're searching it. And then you go to the doctor. I've seen cases where the patients know more than the doctor. They'll come in, doctor, I have complex regional pain syndrome, and did you know that in 2018 a journal came out saying, and the doctor said, oh my freaking word.
Oh, and the doctors don't like you being on the internet, though.
Oh, they don't, because here's part of the problem, is your average doctor doesn't have time to research and study. This is a bizarre form of stealing freedom. Medicine has become so corporately and vertically integrated that doctors' time has been so compressed that if you're in an orthodox medical practice, you're spending a ton of your time banging a keyboard and filling in boxes so you can get paid, so your records can pass muster when they get audited. The average doctor spends 2 hours a night, they call it pajama time, mopping up records. 2 hours. We don't do that in intellectual medicine. No, we keep records, but we don't. That's part of the reason we stepped out of insurance life, so we can have time to study. So there the patients are studying this, and they go, oh, wait, it's like Martin Luther saying, wait, you guys can read. You guys can read. Oh, there are no indulgences in the Bible. You guys can keep your money in your pocket. Like, whoa. So that's a little bit of what my patients experience. They start to read things, and they start to pursue their own path. And just like the Reformation, where the Orthodox Church said, whoa, this is heresy, there are some in the realm of Orthodox medicine that are saying, hey, this is heresy. We must stop intellectual medicine. We must stop Dr. Petteruti because he's going to confuse people. One of the doctors who opposes what we do wrote a complaint. What I found most fascinating is the line of the complaint is, who's been offended, who's been harmed. And the line said, the people of Rhode Island, speaking on behalf of the entire state to protect them from our misguided and confusing and fraudulent pathways. Okay, so the Reformation is underway. It won't be stopped. I mean, they can, you can hang the leaders at the beginning, but it's going to happen. And we, doctors, need to get more and more comfortable in that collaborative environment. In particular when it comes to cancer.
Yeah, we need choices.
And you want to have the collaborative approach. You shouldn't be put in a position of choosing between the study and what you want to apply.
Right.
Should not be given that.
Right. We can't integrate anything with their protocol.
I'll tell you about a hopeful case in a moment, because that's what we're looking for. We're looking for something weird to happen here, right?
Yeah,
We
absolutely.
wanna
That's why we're here.
We
That's
want to
why
be the
we do what we
case
do.
study, and we have to balance that against the possibility that it could not happen. That you're risking time and money that could be wasted.
Right.
I don't think it will be.
It won't be.
You got to talk to Lois Greco. Have you met her yet?
No.
Yeah, she had stage 4 cancer about 3 years. She's a performer. She's on stage every weekend.
Oh, wow.
She's got brain tumors.
Wow.
Feels great. I'm back, everybody. I am back. We were just having a great time off air, and we're going to get back to Paul and Carolyn. Paul has been diagnosed with stage 4 glioblastoma multiforme, the worst form of brain tumor that you can have. Paul does not screw around. He does nothing halfway, including when he gets a diagnosis.
Extremist.
He's been given a prognosis according to the prognosticators from the time of diagnosis. Median lifespan 14 months. You're about halfway into that. It affects everything. And we were just talking about the contrast. When there's, and in intellectual medicine, we've had some patients that have been adamant they do not want to do chemotherapy, and we've had to say to them, are you nuts? Your cancer is exquisitely sensitive to chemotherapy. You'd be a fool not to pursue it. We've been able to guide them toward that pathway. And then you have the other case. So I had this patient, and she came to me a few years back, and she had a pancreatic cancer. And she said, doctor, I don't know what to do. I have an option to do conventional therapy, and there's another surgeon. I believe his name is Dr. Harry Wanabo, I want to say, because I never met the man, but I admire him by reputation. And he had a reputation for being a little bit crazy, as some people would put it, because he did things nobody would do. And she said, I could go to this other surgeon. He's going to do this like stuff that nobody will do, and what should I do? I said, the conventional therapy is going to give you a conventional outcome, and you're likely to succumb to the disease as would occur otherwise. I said, I don't know what this other guy's doing. But if the choice is conventional versus what's behind door number 2, I'm kind of voting for door number 2. I saw her 8 years later at a restaurant, having survived her cancer. A cancer that really statistically should have claimed her life. Now, without false hope and with eyes wide open, we move forward. Mm-hmm. And if we know, now what you guys are doing right now, well, I'll turn it back over to you. So there you are, the study protocol, you're getting your chemotherapy currently, contemplating whether, why not continue it though? I mean, if it's what they're offering.
I mean, that's what we're faced with, that decision all the time is, should we continue? But everything we research says it's the chemo that ultimately kills you. Your immune system is so significantly impacted that it's very difficult to come back and recover from that, especially if I'm going to have a total of 7 rounds of chemo already scheduled.
And the Temodor chemo that they've already told you has very little
impact on this type of glioblastoma because it's unmethylated. Correct. So, I'm in a good standing right now. We're very anxiously awaiting the next MRI. If we don't comply with this trial and do this round of Temodor, then I don't get my next MRI. And we really want this MRI to make sure everything looks good up there.
Yeah, I want to pause for a moment and highlight that to our listeners. To me, that's a form of therapeutic coercion. If you're told that if you don't adhere to what we're telling you we want you to do, we're going to cease doing imaging studies to track your malignancy.
Right.
Is that the yes, Carolyn?
No, they won't completely do that. They would just monitor you.
Would they do the MRI?
They would do an MRI, but it
Okay.
wouldn't be as frequent as the trial says
okay.
they're going to do it on. But they would do it, but it would be
Right.
a longer
right.
stretch in between. And
All right, well,
this is
that's
something
okay,
yeah.
though. That's okay.
Yeah, so in this trial here that we're on, it's supposed to be an MRI every 8 weeks.
Right.
But if not, then it would be every 3 months is a typical MRI frame.
All right, so that, by the way, that's totally cool.
Yeah.
Because the MRIs are going to be markers. The most important marker early on is kind of how you're feeling.
Yeah.
How are you feeling?
I feel pretty good. I mean, I have some of my ups and downs, but since I've been doing the high-dose vitamin C IV, I think that's had a nice benefit for me. We've added the mistletoe to that as well. So I think those alternative options help me because the chemo takes you down.
Yeah.
So if you need to find something that helps counter what the chemo does to you.
Now, the studies on vitamin C have supported that perception by patients. It decreases some of the negative effects of chemotherapy. Now, there are cases where it has that complementary role supportively. Now, how did you come to even know that this type of treatment was out there?
Oh, man, well, I got to give my wife, Carolyn, most of the credit. She does so much research, it's crazy. We have a good friend. I hope I can mention his name.
It's up to you.
Greg Gentili. I hope he's listening. He knows you well.
He's a great guy.
He's been here. So he mentioned you, and Carolyn's done quite a bit of research, and we located your center out here as well. And
Carolyn, tell us about some of your research. How did you go about that? What motivated you? What were you looking for?
Well, when he was in the hospital, I kind of just picked up on words the surgeon had said.
Yes.
And which Paul hadn't. And I knew what we were up against before he was even discharged from the hospital. I was just on, and not just Googling sites and these, there are fake sites out there,
Right.
But it was actually medical sites that it would bring me to on different studies and things they did.
So now you can get to the same things that we doctors read.
Right.
You can
right.
get to
government
PubMed
sites.
and you can look
Yes.
at NIH. Sure.
Yes, exactly. Exactly what I go on a lot of the times.
Right.
And I'll look at studies and I'll even bring things up to the doctors. And
which they love.
They really love that. They actually did some extra blood testing on him because they said,
That's
the
great.
virus CMV, Epstein-Barr, and Lyme disease have been linked to it. Has anybody tested him for it? And I said, it's just a lot of different things that they're not bringing to us. They're just,
Right.
I think they just figure he's a lost cause. Like the radiologist before, on our first meeting, he said to him, we told him about the diet, and he's like, oh, go eat what you want. Go have that steak and that beer. Go do what you,
have all the sugar you want.
Have all the sugar you want. Your brain needs sugar, he said. So it's
So
just
it's a different philosophy.
It's a different philosophy.
There are some, and by the way, there's some patients that embrace that philosophy, which is sort of fatalistic. You know what? I've been given a death sentence. I've got only so many days left on the planet. By golly, I'm having a T-bone.
Yeah.
And that's okay, because that's part of the freedom and philosophy aspect of it. Now, there's a host of different treatments out there when you're reading about them. Did you read about vitamin C prior to coming to our center?
We learned about that from a show, The Truth About Cancer, which was on the internet. They did it through Asia, and where Asia actually gives you, certain countries will actually give you the choice of, do you want to go to the doctors or do you want to do holistic? And the insurance covers what they want to do out there.
Right.
They have a choice. They actually, even though
do either or both.
Either or both.
Yeah.
And that was a great
and
series.
And it kind of like put things in our head, and we're writing things down. So as we're researching, Greg had, just messaged us out of the blue about this center. It's like, that's exactly what we're looking for, because I was all over the internet looking for a local place.
It's so hard. One of the reasons that we established, and we have great support from our patients, great support from the community at large, and a lot of individuals would be stuck having to go great distance to receive care such as vitamin C and others. You'd have to fly to Kansas, and University of Iowa is where one of those studies came from that I quoted earlier, where they do vitamin C concurrent with chemotherapy and other modalities right in the oncology ward. So it's really commingled. New England is not quite as embracing of some of those alternatives. So how do you react when people tell you there's no evidence that vitamin C is going to cure your cancer? There's no evidence mistletoe is going to cure it. You could be wasting time and money.
Well, that's okay, because it's given us hope.
Yeah.
It can't hurt us. I do see that he has more energy.
Well, it can hurt. It can hurt time and money.
It can hurt time. Time and money.
It hurts
we
your wallet
have
a little
nothing
bit,
to
but-
lose, but if it gives him extra time,
I mean,
and it makes him feel better.
If I can interject a little bit, we've done enough research in The Truth About Cancer. We watched that series. They had 2 different series with some of the most well-renowned doctors around the world, and they've discussed the benefits of vitamin C in multiple different studies in their countries.
Right.
So, granted, it's not so readily available here, but I'm very grateful that it is, that we can get some of the care that these people in Malaysia and Singapore and China, Japan, all over the place, they're seeing success with that.
Well, it's getting much more widespread, and we look forward to continuing that work. One of our objectives at Intellectual Medicine is to establish a cohort where we can follow people over months and years, and this is a type of information that we need to gather. We're seeing case studies that are very promising, even in our center. We're seeing cases of people with very ominous forms of diagnoses that are really exceeding expectations. It's not universal, and people do succumb to their cancer, and you guys know that that could be the outcome, and that statistically speaking, that's likely to happen. And therefore, we ignore the statistics to a degree. We honor and respect them, but you sort of disregard them and you take your best play. Now, one of the things that we've done is combine mistletoe with vitamin C, in part because what we've noted from our conventional oncology colleagues is combination therapies seem to work better when you fold things together. Cancer cells are very sneaky and capable of dodging effect from singular therapy. Mistletoe works in part by upregulating your immune response. It also has lectins that are toxic to the cancer itself. So working on both aspects, and you're right, Paul, your immune system is what fights the cancer and keeps it in check. And our objective is to put it into a long, extended period of remission. We believe that cancer in many cases can behave like a chronic illness. And one of the problems with regional centers that you would fly to and get intensive care for a month and then fly home is the lack of ongoing continuity. So our approach is to start out intensively and then stretch it out and stretch it out. And you know what? In 4 years, if we're doing vitamin C once a month or once every couple weeks, fine. We've had cases like that. As long as our patients understand that what we're doing represents a form of clinical experimentation. That is, we can't tell you that, yeah, we've done this for 20 years and here's a study and it's got X% outcome, because it's formative. We're taking scientific evidence, safety, efficacy, and applying it right now. And folks, this is the part where we get to help and be part of the same community. For this to work, we've got to have it available. For it to be available, we've got to be able to talk about it. We've got to be able to have people reflect on its presence. And one of the things we're advocating for, I'm going to talk about right after we take a short break, because they're getting nervous there about what's coming next, right? Got a short break coming up, folks. This is Dr. Steve Petteruti with Paul and Carolyn. We are Intellectual Medicine, talking about glioblastomas today. We'll be right back. We could well be talking about medicine more globally. You know, it's not just glioblastoma. It's not just cancer. It's heart disease. It's fill in the blank. It's infectious illnesses. You know what? If it weren't for a Z-Pack, I don't think walk-in centers could exist.
Right.
You see an infection, you throw an antibiotic at it. Well, what about your body's own immune function? We have in our infusion center, we have an infusion called the Shield. Now, the Shield is a mixture of high-dose vitamin C with zinc. These are a couple of micronutrients that are known to be central to immunologic functioning. Now, the criticism against it is, well, it's not proven to work. Okay, that's a true statement. We can't do a study to prove that the Shield will shorten the duration of a rhinovirus. Well, that study is beyond the financial capacity of what we do. But the way the human body works, we know how it works. We know what elements support natural immune function. We know it's safe. The only thing people are risking is time and money, and that's relevant and needs to be reflected upon. But compare that to an antibiotic. We know that 95% of upper respiratory infections are viral, and antibiotics cause harm. They cause harm. They weaken your immune system. They destroy the bacterial balance in your colon in a manner that can be durable, lasting months. So, you know, Orthodox medicine has its place, and and you guys demonstrated that well. Without that craniotomy, we're not having this conversation.
That's right, yeah. They gave me 4 weeks. Yeah.
Without it.
Actually, even after the surgery, they said if you don't go for radiation and chemo, you have 4 weeks. And they said with treatment, meaning radiation and chemo, you have 14 months. So yeah, can you imagine it was blowing up in size so fast?
So the MRI after the 4 weeks already showed a 1 centimeter. So in that 4 weeks after just about a complete
Surgical recession.
it was already like 1.2
centimeters.
1.2
centimeters, yeah.
And then they did the radiation. How long? They waited about a month?
There was a good delay before radiation started, because when they were supposed to do the methylation test, they never did it. They threw the request away, and it takes 2 weeks to get the study.
Oh, that is galling.
Could have been a major lawsuit there, but they forgot to do the test, and the doctor in our cancer institute was at least courteous enough to tell us the truth why they're waiting so long. He said, you've got to get on something now because it could come back so fast. It's known to come back as fast as you know, and then when they give you 4 weeks, it can come back in 4 weeks the same size as what it was.
So I do believe the radiation was definitely needed, and
Yep.
I believe that, you know, that's
Radiation
what
chemo
got
was
rid of it.
needed.
That was what was needed, was the radiation.
I mean, I'm on my
The
fifth
chemo
round.
part actually
Don't
affects
know.
your whole body.
We don't know,
Yeah.
and this is your dilemma, right? Because
Your immune system, right?
you know, although the drug has been, I don't know enough about the drug to have a thoughtful input regarding your decision. You probably know more than I do about its potential merits. But that's a difficult decision.
Yeah,
'Cause
because we
when-
can't pick. We don't
When,
got
when you walk away from the chemo, if they say, well, it might help a little, you don't know if it's enough to be worth
Right. Is
taking.
it working for him? Every single person is different.
Some
You
people
know,
have had more success with Avastin. And in my situation, that might have been preferential, but because now you've signed up for the trial and the computer picks you, I call
Now-
it short straw. You need to be the baseline.
But you have to be in the study to then qualify for what comes next.
Right.
So if you drop out of this study, you don't get a chance
we
to
won't
come into another
qualify.
one.
We won't qualify. We've
Right.
already even spoken to somebody over at Duke, and the polio virus, which they put into the tumor itself. But each person is different. We might not even qualify for that if he had a 1 centimeter again.
And the tumor has to come back.
And he had the 1 centimeter tumor, but it wasn't considered a reoccurrence because he didn't do standard of care yet.
I
A
see.
lot of trials are after reoccurrence comes, but
Right.
that's after the whole
And,
duration of the
in,
standard
and
of
in
care.
order to be capable to be in that, you've got to complete. If you drop
That's
out of
right.
this, you're like
You didn't, right.
you get kicked out of the club.
That's what I
Kind
meant.
of,
That's what
yeah.
I meant earlier. If I don't finish this, and I think that's when you jumped in too. But if I don't finish these 7 rounds of chemo, and
Hey gang, we're back. It's Dr. Petteruti at Intellectual Medicine. We're here with Paul and Carolyn. Paul is diagnosed with a glioblastoma. He's been talking about his journey, getting his decision making. He's in chemotherapy currently, having surgery to remove the tumor, or a lot of it, followed by radiation therapy. Now, they never get it all. The idea of when you hear the surgeon say, we think we got it all, you're not getting it all. It's a cellular disease. The cells fragment and they float through the blood. We now have available blood biopsies. You familiar with these? Called a liquid biopsy. They are being developed in individual labs. The FDA has 2 means of approving tests. One is, let's call it a kit that any lab can do, and it's standardized. So if you want to get, I don't know, let's say you want to get a cholesterol done, or you want to get a prostate-specific antigen test, any lab can do it. Then the FDA will endorse lab-developed testing, and there are 2 labs that we like, that we utilize. One of them is Biocept, the other one is IVGene, and they can now measure for circulating tumor cells in the blood. So if you've ever had, for instance, prostate cancer, we did this on a gentleman recently, and wondering, well, where is it? The problem with imaging is it's got to be big enough to see. And to be big enough to see sometimes requires 20 or 30 tumor doublings in order to grow large enough to be visible. Well, glios grow fast. If you have something like a prostate cancer, a doubling time could be 3 months, from 1 to 2 cells, 2 to 4, etc. So the notion that we can catch it early because we can see it, well, early is a relative term. That may be years into the cancer's development. So we know, for instance, with breast cancer, that there's a delayed relapse rate that's significant. Even in women that have had stage 1 breast cancer, we're talking beyond 5 years, 12%, 10 to 12% relapse rate. And you can't see it on imaging. So this is where I love this blood biopsy idea, that you can look for circulating tumor cells. In some cases, the methylated DNA of the cancer leaves a fingerprint. They haven't developed it yet for glios. They've developed it for other forms of cancer. IVGene has one for colon, breast, liver, and lung. And the way to use this study is, in many cases, ironically, when you feel great and the cancer's in your rearview mirror, because it always looms a shadow. But I want to turn back to the circumstance you're in. We were just talking a moment ago, you're in the chemotherapy. Talk about the trial that you're in and the effect of going forward in the trial versus choosing not to. I thought that was interesting, that if you decide you don't want to stay in the trial, you lose eligibility for further studies. Is that the case?
yeah, it kind of it stifles your options. So it's very important that we follow through with this trial, which is I'm in the middle of my 5th round of radiation. Of chemo, and I have 2 more rounds to follow this. If we decide to bail out of this, the Cancer Institute did say you're allowed to, but you're going to lessen your opportunities. You will not be able to pick and choose your next trial or your next medicine because you didn't follow through with this initial standard of care approach that they put us on.
You're a quitter.
I'm a quitter, right?
We'll throw you out of the club.
So there are things we can do. I take my chemo orally, and I can, every day I can throw half of those down the drain and monitor my own dosage if I feel that it is destroying my immune system.
How does it make you feel? Is it hit you, or is it
It hits me. It's the tiredness. It really takes you down.
Yeah.
I've been lucky that the nausea hasn't hurt me too badly, but I have 3 different prescriptions for nausea.
Right.
And I can take pretty much any cocktail I want of those 3, so I can combat it. I'm not a big fan of
So energy is a big deal with many of my patients. Strength and energy.
For me, I go to the gym every day, or at least I used to, and I miss that, so I want to get back into that. So energy is definitely a big deal.
And we just started testosterone therapy.
That's right.
And that's not aiming at the cancer directly, but we did find through blood testing, and this has been my experience broadly, patients that are being affected by cancer and chemotherapy, not only is the immune system obliterated, weakened, but the pituitary gonadal axis is often adversely affected, and they suffer low testosterone effect, men and women. And that manifests itself as weakness, physical power reduction, which gets labeled or ascribed to the cancer itself. And if you ascribe it to the cancer itself, well, there's no treatment other than treating the cancer. So we just started that, and it'll be interesting for us to observe together
for sure
the effect it has. I know it's a bit early to judge.
Yeah, I think it's helping. I was just talking to my wife about this, I believe it was yesterday. I'm not sure what combination has given me more energy. I'm assuming it's the vitamin C.
Right.
It could be the mistletoe that we recently incorporated too. I think I've done 4 injections so far of the mistletoe.
Sure.
And the testosterone, I believe I've done my 5th injection, which was yesterday.
Right.
I'm not sure if it's a combination of the 3 or what, but I have had better energy levels, right, Carolyn?
Yeah.
She's always
less
saying
napping.
I used to
less
be
grogginess.
I was a couch potato. It was terrible, and I'm still on the chemo, right?
Yeah. So good. I mean, it's good in that if the energy's on an upswing, that's beautiful, and it maybe takes some of the pressure off having to consider coming off chemo. Ironically,
right.
Because if the energy is on an upswing,
right,
and this is if we're not certain what's helping, but we know that nothing you're doing is of harm.
Right, it's quality of life.
It's all part of that equation. There it is.
And I think it's important that we all should realize, right, that the chemo has a negative impact to our immune system, right?
Yeah.
From all the research that we've done, chemo is bad for your immune system. And if we can take supplements, which I take a boatload of supplements, and if we can change our diet, good nutrition, and do things like vitamin C and mistletoe and other things that can help our immune system, I think maybe we can fight the effects of the chemotherapy. Otherwise, if I'm not putting anything else into my body but the chemotherapy, I don't feel like I stand a chance. Now I have options.
We're targeting for all of us, and our time's running short. This has been a beautiful conversation, but we're targeting for you, for me, for you, Carolyn, for all of us. We want a rectangular lifespan. We want to live robustly, and then just die quickly. That's like hopefully no time soon, right, Paul? We gotta make it till August. What's happening in August?
August. Oh, my daughter's getting married. We can't miss that.
We're supposed to be snowbirds.
Oh, we're supposed to be snowbirds. Yeah.
So
he's got many years to go.
So we have plans. We all have plans, and the plan doesn't include getting interrupted by an illness, but God forbid it occurs. We live every day embracing our best health. Remember, people, you don't have health insurance. You have sick insurance. And if you want health, you better do your own homework like Carolyn and Paul have done. Give it thought and reflection. If you are afflicted with a severe illness, be it cancer or heart disease, broaden your view. There are options out there. And if you're living in good health in the moment, if you're temporarily well, count your blessings. Enjoy your Mother's Day 3-day weekend.
3-day weekend.
And stay with us. I'm Dr. Steve Petteruti. This is Intellectual Medicine. We're wishing you 120 youthful years.